Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. I'm Lewis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. Let me pause for a moment. Captioner. Okay, there we go. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in the meeting control toolbar. To turn that meeting control toolbar on, you press the Alt key, and you can press it again to make it stay. As always in our sessions, only the speakers will have audio. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900. 9128 or 1-646-558-8656 and use the webinar ID of 864-8854-2838. I want to remind you that this webinar is being recorded and can be accessed at the adapresentations.org website in the archives section of Healthcare next week. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990, the ADA. Upcoming sessions are available at adapresentations.org under the Schedule tab, and then follow to Healthcare. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific time. You'll notice that today's is not on the fourth Thursday, but we had to have a reschedule. By being here, you are on the list to receive notices for future webinars in this series. The notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along on the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the Healthcare Schedule page at adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform. The speakers and I will address them at the end of the session, so feel free to submit them as they come to your mind during the presentation. To submit your questions, you can type them in the chat area text box, or if you are using keyboard only, you can press Alt-H and enter your text. If you are listening by phone and not logged into the webinar, you can ask your questions by emailing them to us at ADATech, that's ADATECH, at adapacific.org. If you experience any technical difficulties during the webinar, you can send a private chat message to us at the host by typing in the chat window. And again, if you're using your text keyboard only, you can use Alt-H to access that chat box and enter your information and enter. You can also email us at adatech@adapacific.org, or you can call us at 510-285-5600. Today's ADA National Network learning session is titled Achieving Equity in a Time of Scarcity, Lessons from the COVID-19 Vaccine Experience. This presentation will review the experiences of Medicaid beneficiaries and people with disabilities in California and nationally related to vaccine prioritization and deployment, and reflect on lessons for policy and practice that will support greater equity moving forward. Today's speakers are Andy Imparato. Andy is the Executive Director of Disability Rights California, a $34 million legal services organization that serves people with all types of disabilities across California. He serves on California's Community Vaccine Advisory Committee, and in February of 2021 was appointed by President Biden to serve as one of 12 public members of the Biden-Harris COVID-19 Health Equity Task Force. Priya Chidambaram is a senior policy analyst with the Kaiser Family Foundation program on Medicaid and the uninsured. Her research focuses on Medicaid for seniors and people with disabilities, including issues related to people dually eligible for Medicare and Medicaid and long-term supports and services. All right, Andy and Priya, I will now turn it over to you.
Great, thanks so much, Louis. Hi, everyone. My name is Priya Chidambaram. I'll be starting off our presentation today. As Louis mentioned, I'm here from the Kaiser Family Foundation, also known as KFF, to talk a bit more about our research on COVID-19's impact on people with disabilities, as well as Medicaid's role more broadly for people with disabilities. My presentation will be drawing heavily on KFF's research, both from over the last year as well as prior to COVID. And I'm happy to share the links to the reports and issue briefs that I reference to anyone who is interested. Next slide. I'll start today by discussing COVID-19's impact on non-elderly adults with disabilities. I'll go through the data gaps and research findings that we've identified in this area and discuss how all of that manifested itself into state vaccine prioritization plans. I'll then briefly touch on new CMS vaccine reporting and education rules and how they apply, or more accurately, don't apply to many community-based congregate care settings. I'll then lay some groundwork on Olmstead and the ADA before I spend the rest of my presentation talking about Medicaid's role in reducing institutional bias and other areas where Medicaid overlaps with the ADA. I'll wrap up by discussing some of the recent policy proposals around Medicaid HCBS. Next slide. So since the start of COVID, KFF has been tracking cases and deaths in long-term care facilities fairly closely. And we found that nearly all states report some amount of data on cases and deaths in nursing homes and assisted living facilities. However, those are settings that tend to serve older adults. We wanted to know more about what data was publicly available on settings that primarily serve non-elderly adults with disabilities, primarily to see whether states were working with the same amount of information for both older adults and non-elderly adults with disabilities as they were beginning to design their vaccine prioritization plans this year. The data on the map on this slide was collected in February of 2021, and we found that at that point, just 31 states were reporting any data on COVID-19 cases or deaths in settings that primarily serve non-elderly adults with disabilities. We're talking about settings like group homes, personal care homes, adult day programs, intermediate care facilities, and psychiatric institutions, settings that span from the home and community-based side of things to the institutional side of things. And I just want to note here that not all states report all of these types of settings I just mentioned. In most cases, states only report a few or just one of these types of settings. This data collection process, we did try to exclude settings that primarily served elderly adults, such as nursing facilities and assisted living facilities. There were two major findings from this data hunt. The first is that there is a lot of missing data. The second, there is enormous state variation in reporting, which makes it very difficult to compare between states or have any sort of complete understanding of how people with disabilities have been impacted by the pandemic. Just among states reporting this data, again, as of February 2021, we found over 111,000 cases and over 6,500 deaths due to COVID-19 across these settings, which we assume are primarily non-elderly adults with disabilities. We found that 8 states reported data for some sort of institutional setting. We found that 8 states reported data for some type of home or community-based setting, and 15 states reported data for some type of setting in both of those categories. There was also huge state variation with regards to whether states were reporting cases or deaths, data on residents or staff, active outbreaks versus cumulative cases and deaths. And we also found that states were using different definitions and categorizations for the same types of facilities, making cross-state comparison extra challenging. Another challenging aspect of this data collection was actually contextualizing the numbers that states were reporting. And I'll give you an example of this. If a state reported that there had been, for example, 300 cases of COVID-19 in group homes in the state, we were often given very little additional context of, first, how many group homes those cases were spread out between, and also what share of group home residents that 300 cases actually represents. This is in contrast to the data on cases and deaths available in nursing homes. We have very clear resident census numbers to contextualize the impact of COVID-19 on nursing homes, but we don't have this level of data available to us to contextualize the impact of COVID-19 on settings that serve non-elderly adults with disabilities. Next slide. We also identified other research on the impacts of COVID-19 on people with disabilities, and we flagged a few running themes throughout our findings. First, we found that people who were receiving long-term care in settings other than nursing homes actually faced very similar COVID-19 risk factors as their nursing home counterparts. For example, people with disabilities often rely on close physical proximity to caregivers for communication and daily needs, and this limits their ability to socially distance, very similar to residents in nursing homes. There's also a strong body of research indicating that those with IDD specifically are at greater risk of contracting and dying from COVID-19 compared to those without IDD. A study of private insurance claims actually found that people with developmental disorders, sort of across the spectrum of developmental disorders, had the highest odds of dying from COVID-19, and those with intellectual disabilities, such as Down syndrome, had the third highest risk of death from COVID-19. Research also suggests that people with disabilities who are members of racial or ethnic minority groups are disproportionately affected by COVID-19. For example, counties with higher rates of COVID-19 were also home to disproportionately higher shares of Black, Asian, Hispanic, or Native American people with IDD. The Ways and Means Committee also put out a report finding that Black working people with disabilities were more likely than other racial or ethnic groups to have lost their jobs during the pandemic. People with disabilities also have an increased risk of adverse health outcomes due to workforce shortages, interruptions in care, and overall lack of care during this pandemic. We found that for this population, In-home services were often suspended, and some workers declined to enter client homes due to health and safety concerns. People with disabilities have also faced discriminatory access to care and care rationing based on disability status, which is an issue that predates the pandemic, of course. Direct care workers who also provide LTSS to people with disabilities outside of nursing homes were also found to have faced increased risk from COVID-19. For example, a House Oversight Committee report found that behavioral health treatment facility staff were more likely than the general population to contract COVID-19. Next slide. As far as state vaccine plans go, while everyone now 12 years and older can get a vaccine, that was not the case earlier this year. When we first looked at state prioritization plans back in February, only a few states specifically mentioned people with disabilities or people with any high-risk medical conditions in any of their priority groups. So first, we can back up and talk about how exactly state plans were put together. In December of 2020, ACIP, which was the group that was putting together these federal recommendations for vaccine priority plans, ACIP recommended that healthcare personnel and long-term care facility residents be placed in the top priority group, phase 1A, for COVID-19 vaccine distribution. The ACIP recommendations defined long-term care facilities as nursing homes and assisted living facilities. All state plans that came out soon after that abided by these guidelines and included people in nursing homes in phase 1A, and most also included those in assisted living facilities. The additional ACIP guidance came out at this point that noted that states could choose to include people who reside in congregate living facilities, such as group homes. States could place them in the same priority group as frontline facility staff. However, states were given discretion about which groups to prioritize in their vaccine distribution plans, so state plans ended up varying widely in their comprehensiveness, transparency, and some offered far more details on which populations were being prioritized than other state plans. Some examples of states that did include people with disabilities relatively early on include Tennessee and Oregon. Tennessee prioritized people ages 18 to 74 who were unable to live independently. Oregon prioritized people with disabilities who received services in their home. Both of these states prioritized these population in phase 1A, the same priority level as people in nursing homes. Maryland and Ohio included people with developmental disabilities in phase 1B. Illinois included people with disabilities in phase 1B, and Nevada and Washington included people with disabilities in phase 1C. Although in the state of Washington, this population was limited to those with disabilities that prevented them from adopting protective measures such as social distancing. California was also a state that received a huge amount of attention early on for not prioritizing people with disabilities, which I'm sure Andy will touch on, so I won't go too much into it. But one policy that California adopted was allowing healthcare providers to use their clinical judgment to prioritize people with disabilities if they thought that that particular individual were likely to develop severe illness or die due to lack of access to a COVID-19 vaccine. All in all, few state vaccination plans explicitly mentioned people with disabilities early on, although some did mention people with, quote, high-risk medical conditions, although we know that certain high-risk medical conditions may include some, but not all people with disabilities. Since then, vaccine plans have changed drastically. So looking back on where people with disabilities ended up in these priority lists, we found that over half of states included people with disabilities or people with high-risk medical conditions in Group 1B. And by Group 1C, nearly all states included at least some people with disabilities in their priority lists, although many states prioritized certain subsets of people with disabilities, such as older people with disabilities, those specifically residing in congregate care settings, or those with IDD. Plans that mentioned other long-term care settings did not typically place them at the same priority level as nursing homes. So it was pretty rare to have other long-term care settings mentioned at all. And in addition, few plans explicitly mentioned direct care workers who provided long-term care in settings other than nursing homes. Next slide. CMS issued an interim final rule with comment period that established new vaccine reporting and education requirements for nursing homes and intermediate care facilities for IIDs as of May 21st, 2021. The main takeaway here is that CMS is not enforcing all rules on all types of facilities. Under this new rule, only nursing homes would be required to report data on vaccines and COVID-19 therapeutics, and only nursing homes and ICF's IIDs would be required to educate residents and staff about the COVID-19 vaccine and offer the vaccine when available. CMS excluded inpatient behavioral health settings and congregate community-based settings from these rules, although they did include some language explaining why. CMS noted that inpatient behavioral health facilities were excluded since individuals in these types of facilities may only be inpatients for a short period of time, making a 2-dose vaccine series challenging to administer, and CMS can't guarantee the availability of a single-dose vaccine. As far as community-based settings go, CMS encourages collaboration between these settings, which include settings such as group homes and personal care homes, to partner with state Medicaid agencies and state and local health departments to learn about vaccine distribution options and facilitate vaccination for folks who live and work at community-based settings. Next slide. So shifting over to Medicaid more specifically, I'll start by laying the groundwork on Olmstead and the ADA, as well as implications for Medicaid. I won't go into too much detail here because I believe that previous specific ADA webinars have touched on this topic. But just to lay some groundwork here, in June 1999, in Olmstead versus LC, the Supreme Court held that the unjustified segregation of people with disabilities constitutes discrimination in violation of the ADA, or the Americans with Disabilities Act. They ruled that the states have a community integration obligation when serving people with disabilities. One thing to note about this particular ruling is that it does not specifically change or interpret federal Medicaid law. This particular case was not about the structure of state Medicaid long-term care budgets, but rather about how states, when budgeting their public programs, need to avoid institutional bias against people with disabilities. All of that being said, this decision does have major implications for the Medicaid program, since Medicaid, as I'll note on the next slide, is the main payer for long-term supports and services. And this includes the home and community-based services that many people with disabilities rely on. I'll spend the next few slides going over examples of how the Medicaid program has reduced institutional bias over time, in part due to the June 1999 Olmstead decision. Next slide. So a bit of historical context about the Medicaid program. Medicaid was created with what's called an institutional bias, meaning that state Medicaid programs have always been required to cover nursing home care, while most home and community-based care is optional. Because of this, Medicaid long-term care spending used to be heavily concentrated on institutional spending. However, over the last several decades, there has been a shift in spending from institutional care to home and community-based care. And in 2013, spending on home and community-based care surpassed spending on institutional care for the first time ever. And in 2018, home and community-based care comprised 56% of total Medicaid long-term care spending. We've seen this shift over time for a few reasons. The first beneficiaries tend to prefer receiving care in their home or in their own communities. So if states are offering that option, beneficiaries are more likely to take part in that option. The second, states also like HCBS because it's typically cheaper to provide than institutional care. And finally, what we talked about earlier, states have a community integration obligation under the ADA and the Olmstead decision. Next slide. There are a few major federal grant programs that have played a key role in reducing Medicaid's institutional bias. And the first one I'll mention is Money Follows the Person, also known as MFP. MFP is a demonstration program that helps seniors and people with disabilities move from institutions to the community by providing enhanced federal matching funds to states since 2007. The program operates in 42 states and has transitioned over 100,000 people as of December 2019. The program is often credited with helping states establish formal institution to community transition programs, and states have used MFP funds to offer housing-related services and hire housing specialists to help beneficiaries locate affordable and accessible housing, which is routinely cited as a major barrier to transitioning folks from institutions to communities. The other major federal grant program I'll mention is the Medicaid Balancing Incentive Program, which was a demonstration program established by the ACA. Developing and expanding home and community-based alternatives to institutional care has been a priority for many state Medicaid agencies, and states have made significant progress over the last several decades in increasing the percentage of long-term care dollars that go towards providing HCBS. The ACA established this balancing incentive program as an option available to states to support that rebalancing effort. If states rebalance their Medicaid LTSS spending to spend more in HCBS, as well as implement required structural changes to their Medicaid LTSS programs, they were eligible to receive enhanced federal funding. Many of the participating states met the infrastructure and rebalancing requirements, although there was some state variation in how successful the program was. Next slide. Another way that Medicaid has taken steps to reducing its institutional bias has been to align its eligibility criteria for receiving HCBS and institutional care. One of the ways that state Medicaid programs provide HCBS to its beneficiaries is through what's called an HCBS waiver. This slide here shows that for nearly all waivers, functional and financial eligibility criteria is less stringent or the same as eligibility criteria for institutional care. For only a few waivers is eligibility criteria more stringent than it would be for institutional care. Next slide. The last area I'll touch on here has to do with pathways to expanding financial eligibility for Medicaid long-term care and aligning these expanded financial eligibility rules across different long-term care settings. So many states have taken steps to allow for slightly higher income beneficiaries to qualify for Medicaid long-term care. Historically, these paths have been adopted for institutional care. However, states have recently taken steps to adopt these pathways for HCBS as well. And this is important towards that overall goal of eliminating programmatic bias towards institutional care. If people can qualify for institutional services at higher incomes than would be required to qualify for community-based services, they may choose to unnecessarily enter a nursing facility because it's what they qualify for, rather than spending down their income to qualify for home and community-based care. One thing that I'll note here as I talk about these different pathways is I'll be referring to individuals with higher incomes a few times. By this, I mean individuals with incomes up to 300% of SSI. The first thing I'll touch on is what we call the special income rule. The special income rule effectively allows people with slightly higher incomes to qualify for Medicaid LTSS, as long as their functional needs would require an institutional level of care. Historically, the special income rule has more often been applied to institutional care, but states have also recently been applying the special income rule to home and community-based care as well. There's also a rule that allows an individual with higher income to qualify for Medicaid long-term care, as long as their excess income is administered through a special type of trust called a qualified income or Miller trust. Nearly all states that allow Miller trusts for institutional care also allow individuals to use Miller trusts to qualify for Medicaid HCBS. Again, using the same financial eligibility rules for institutional care and HCBS helps to alleviate that bias towards institutional care. And finally, spousal impoverishment rules. If one person lives in an institution and their spouse lives in the community, the spousal impoverishment rule allows the spouse who lives in the community to retain some of their funds for living expenses. As of 2018, 50 states were applying these spousal impoverishment protections to HCBS waivers as well, meaning that if someone is receiving care through an HCBS waiver, their spouse can still retain some funds for their living expenses without needing to spend it all down to ensure their spouse can still qualify for that HCBS waiver. Next slide. The last area of Medicaid and institutional bias that I'll talk about fall into what's called utilization limits. The way that Medicaid HCBS waivers are designed allows states to choose and limit how many people are served under them. And capping HCBS waiver enrollment can result in what we call waiting lists, when the number of people seeking services exceeds the number of waiver slots available. So for example, in 2018, we found that nearly 820,000 people were on an HCBS waiver waiting list nationally. And one thing that I'll note about this data point is that not all individuals on waiting lists may actually be eligible for waiver services. For example, of the 41 states that reported the data on waiver waiting lists, 33 states screened individuals for waiver eligibility before putting someone on a waiting list. The other 8 states did not screen for waiver eligibility. Other types of utilization controls that exist in HCBS waivers include hour limits, cost limits, and geographic limits. And all of those states can implement to control utilization in their HCBS waivers. And these utilization controls have sometimes been cited as institutional bias in the Medicaid program, since these same things don't exist for institutional services. Next slide. So I'll quickly touch on the few policies that are out there that would increase funding for Medicaid HCBS. The American Rescue Plan, which was signed into law a few months ago, included a provision to increase the FMAP rate for Medicaid HCBS by 10 percentage points, which we estimated would mean about an additional $11 billion federal dollars towards Medicaid HCBS in the 1-year time period that additional federal increase would be in effect. And given the fact that this is a time-limited proposal, we think that states will be more likely to use those funds to adopt policies to directly address the pandemic. And this includes policies such as increasing pay for direct care workers or offering more targeted services such as home delivered meals or assistive technology. And the more recent proposal that I'll touch on is the Better Care, Better Jobs Act. And when I say recent, I do mean within the last week. This was sort of the bill that came out of the original infrastructure bill. It is the Democrats' proposal for Biden's $400 billion towards HCBS. The proposal has 3 provisions to expand and strengthen Medicaid HCBS and the direct care workforce, which includes a major provision around HCBS infrastructure improvement. And this offers a couple of different ways for states to receive an enhanced federal match for Medicaid. This enhanced federal match includes incentives for states to adopt self-direction programs, expand HCBS financial eligibility up to the federal maximum, and updating HCBS payment rates and ensuring that those rate increases are passed directly onto direct care workers. The other two provisions in this bill would provide funds to make money follows the person permanent and also make HCBS spousal impoverishment protections permanent. So with that, I'll pass it on to Andy, who will talk a bit more specifically about California.
Thank you, Priya, and great to be here with everybody. So I'm going to try to be pretty brief because I'm looking forward to getting into the Q&A. And as Louis mentioned at the beginning, I am the executive director at Disability Rights California. I actually started this job in February of last year, so right before the pandemic. I got appointed by the state of California to their community vaccine advisory committee during the holiday period, towards the end of last year. And this was a multi-stakeholder committee that California wanted to work with to make decisions related to vaccine prioritization. And it was chaired by the California Department of Public Health and the Surgeon General of California. Our state has its own Surgeon General, Nadine Burke-Harris. So she co-chaired the Community Vaccine Advisory Committee with folks from the California Department of Public Health. Eric Capon was the lead physician who co-chaired the committee, but the head of the California Department of Public Health, Tomas Aragon, who actually started in that role during the pandemic, was also very active. And they had about, I would say, 90 different organizations represented on the Stakeholder Advisory Committee. There were 5 of us coming at it primarily from a disability perspective, and we worked very closely together to make our voices heard throughout the process. So that included, in addition to Disability Rights California, it included the Disability Rights Education and Defense Fund, the California Foundation for Independent Living Centers, and our State Council on Developmental Disabilities. And then the representative from Justice in Aging ended up, his name's Denny Chan, he ended up supporting all of our recommendations. He was wearing a hat bigger than disability, but he definitely saw the importance of prioritizing high-risk people with disabilities. So, the kind of the story from California, as Priya referenced, was kind of a series of ups and downs that were very frustrating at times and got better over time. So in December, the state, following the approach that was recommended by the ACIP group that Priya had referenced, which was convened by the CDC, they had a tiered structure similar to what Priya described. And in that tiered structure, the plan was to basically get the vaccine to people as a priority who were at highest risk of negative consequences from COVID. So a reason to start with frontline healthcare workers is because by nature of their jobs, they were going to get more exposure. They prioritized people in nursing homes, as Priya described, in part because we had data that showed that there were disproportionate deaths happening in nursing homes. And we had a back and forth with the state on how to identify high-risk people with disabilities who were under 65 and over 65. In January, the state decided that the tiered system was going to be too complicated to administer, and they decided a better system would be to do everybody over 65 in California and then kind of go down based on age cohorts. So everybody over 65, then 55 to 64-year-olds and on down. And they estimated at the time that they announced that to our committee that it could take as long as 3 months to get to anybody under 65. So we were very concerned when they made that announcement that people with disabilities who were at high risk of dying from COVID, who were under 65, were going to die unnecessarily because it was going to take us so long to prioritize them for vaccines. And we had a lot of back and forth with the state. In February, they announced that they would start to prioritize people who were at high risk because of the nature of their disabilities, starting on March 15th. And they did honor that commitment. And starting on March 15th, they did start to prioritize people under 65 with disabilities, including everybody who received in-home supportive services through our home and community-based long-term services support system in California, and everybody who received services from a regional center in California, which is our intellectual and developmental disability population. That was something that we had recommended, to create categorical eligibility for people in those two categories, because those are large populations who are inherently at higher risk of getting COVID and dying from COVID. And we made the case to the state that it wasn't worth trying to do an individualized assessment of each person's risk, that would just create barriers to people getting access, and that it would boil down to the quality of the medical evidence that people could present, which was not easy to get during a pandemic. We also didn't want to divert medical resources away from treating patients to make this kind of a showing on an individual basis for people to get the vaccine. We also convinced the state to let people self-attest that they were high risk. So if they were not receiving in-home supportive services or regional center services, they could self-attest that because of the nature of their disability, they were at high risk of getting COVID and having negative consequences from COVID. And the state went along with that, which we were very grateful for. So starting March 15, a very broad group of folks who were high risk with disabilities under 65 were eligible for vaccines. Since March 15th, the state has been doing a lot of different things to try to either bring people with disabilities to vaccines or bring vaccines to people with disabilities, including paying for transportation, having mobile clinics, working with partner organizations on the ground. There have been a lot of creative approaches to getting the vaccine to the community. But we don't have great data. We do have data around race and ethnicity. So we know that African Americans and the Latinx population in California disproportionately still, many of them still have not been vaccinated. We don't have great data on how many people with disabilities are in that category. So, I think I just wanted to reflect on some lessons from the California experience, and then I really look forward to the Q&A. So one lesson, which certainly you heard from Priya, is that we need better data. And the data problem is an interesting one in the sense that it feels like the fact that we didn't have great data about what was happening to people with disabilities during the pandemic was an equity issue. We basically underinvested in data collection, and this obviously predated the pandemic, but we felt the impact of it during the pandemic. And then we used that equity problem in a way that made it worse when we were making decisions about who to prioritize for vaccines. So it's through no fault of their own, the disability community in California we didn't have great data on what was happening to us during the pandemic. And then that lack of data was used against us on prioritization, at least initially. And then we had a back and forth with the state and ultimately ended up in a better place. Second, the public health system in California did not have deep knowledge of the disability community, and they were slow to leverage the knowledge of the disability community that existed in other parts of state government. So eventually we had a task force that was really focused on getting the vaccine to people with disabilities that included the State Department of Developmental Services, the State Department of Rehabilitation, the disability, kind of the access and functional needs manager for the California Office of Emergency Services. all of those agencies had much deeper understanding of where the disability community was, how to get the vaccines to them, how to make the case for vaccine prioritization. They also had deeper knowledge of how to make vaccine deployment accessible for people with disabilities. One of the problems we had in California is we had a number of local public health websites that were not accessible for people with disabilities because the local public health officials did not have that expertise. So, I think there's two pieces to this as we think about lessons. One is for the Department of Public Health to develop more disability competence. And I think they can certainly look to Cal OES as an example, where over the years they've invested in building capacity in-house so that they know how to respond to the unique needs of people with disabilities during a disaster. We need the California Department of Public Health, and I would say all state departments of public health, to develop more disability expertise, similar to what's happened around FEMA at the federal level, and then the California Office of Emergency Services at the state level. Interestingly, budgets for public health have been going down over time. Budgets for emergency response have been going up over time. So I think that's another just factor. There's a lot more capacity in the emergency preparedness and response system in our country right now than there is in the public health system. So I think leveraging that capacity to make better decisions in a pandemic moving forward is going to be important. I would also say the media ended up being a huge ally for us in California. And one of the things that I've found particularly interesting, I've been doing disability advocacy for about 30 years. This was the first issue I worked on, the vaccine prioritization issue, where probably a third of the journalists who reached out to me told me about their own lived experience with a disability. So there were a lot of journalists that really saw this as a personal story. They had a personal stake in the issue. They wanted access to the vaccines, and they understood how important it was, and they made that case. I mean, the LA Times did, I think in 1 week, we had 6 stories on this issue. In 1 week, pretty much every day it was in the paper. And there was a lot of media attention to the issue, which I definitely think helped us get the state of California to change their position on the issue. We also, at a key moment in the discussions with the state, we had a group of physicians in California join us in making the case to our Secretary of Health and Human Services, Dr. Mark Galley, who's a pediatrician. And I think it was really helpful for him to hear the medical case for prioritizing people under 65 with disabilities from physicians. And it was a group of physicians that we had worked with to also convince the state to change their position on crisis standards of care or rationing of things like ventilators earlier in the pandemic. So, sometimes it's frustrating that you need that medical voice as an ally in order to be heard. But I will say that medical voice was incredibly helpful to us as we were making the case for vaccine prioritization and for not discriminating against people with disabilities on crisis standards of care. And then the last thing that I want to say as a lesson learned is, when the vaccines first became available, we asked for the state, because part of the purpose of the Community Vaccine Advisory Committee was to make the case to our various constituencies that we were connected to that it was a good idea to get vaccinated. And we asked the state to give us the best data they had about the efficacy of the vaccine for people with a wide range of disabilities. Like, what do we know about how the vaccine was going to interact with disabilities? Had the vaccine been tested on people with disabilities? Then over time, there were questions about whether it had been tested on teenagers or children. And we didn't have great information that we could share with the disability community. We do now because so many people have been vaccinated. But when they first started deploying the vaccine, we didn't have great data because the disability community hadn't really been identified as a group that needed to be tested, when the vaccine was being tested for safety and for efficacy. And I think that slowed us down in terms of the demand for the vaccine within the disability community. And I think that's still affecting us. There are still folks in the disability community and parents of teenagers with disabilities who are afraid to get the vaccine because they're not sure that it's safe for somebody with their condition. And we don't have great data across lots of conditions that can help them understand why it's safe. So I'm going to stop there. Look forward to the Q&A and appreciate the opportunity to be with you today.
All right. Thank you, Andy and Priya. All right, everyone, this is your chance to submit your questions in the chat area, and we'll get to those as you post them. Let me start off with the first couple of questions that came in. Excuse me. One person, I'm going to summarize this person because we had a discussion back and forth about what she was looking for. So Andy, you kind of covered like the non-institutional, non-personal care portion of the disability community in California, but maybe you or Priya, do you have a sense of how that went for elsewhere in the country? Because Priya, you did a really great job of covering what happened for institutional and HCBS populations, but what about the disability community that maybe was not involved, is not part of that?
Priya, do you want to go first on that?
Yeah, sure. So I could talk about well, I guess my answer will almost be a non-answer. One of the struggles that we had with sort of understanding what was happening on the ground for folks who might not be reflected in state records because they either are not receiving care in an institution or they are not enrolled in a Medicaid HCBS program, is that there's just not really data available. And a lot of the anecdotes do come from journalism and sort of local news that chooses to highlight those individual experiences. And so there's not this there's not this sort of like systemic way that states are collecting and sharing that information. And so from a research perspective, that is not a population that we were able to really get a grasp on in terms of how many cases and deaths there were in that population, what their unique needs and challenges were. And certainly that's something that, that population has been, speaking up. And I think it's much more anecdotal than we would like it to be. But yeah, unfortunately, just because there's just not good data there, we haven't been able to get a good grasp of the unique needs and what has been going on with the population with that level of disability.
Yeah, I would just add from, the work that I've been doing on this federal health equity task force, we have kind of underinvested in disability data collection for a long time. I remember I came to DC in '93 to work for Senator Harkin, and this was during the Clinton administration. And in 1994 and 1995, there was a disability supplement to the National Health Interview Survey that gave us a lot more granular data about what was happening to people with disabilities and where they were in interaction with different government programs and services. And that supplement has never been repeated. So that deep kind of granular information that we got in the mid-90s, part of that was a determination by the leadership in the Clinton administration that it was important to have better disability data. And if there ever was evidence of the importance of having good disability data, it was on this issue of vaccine prioritization. Our lack of good data and comprehensive data was being held against us in multiple states on whether we were a priority population for vaccines. And, Priya, you mentioned that the ACIP kind of process that CDC convened. Interestingly, the ACIP developed a list of conditions that they considered to be high risk related to COVID, and one of the conditions on that list was Down syndrome, but they did not kind of name intellectual and developmental disabilities more broadly. And I think that's because they had data that met their criteria of rigor for Down syndrome, but they didn't have the data for other types of disabilities. And ACIP specifically said that they did not think that their list should be used by states in making decisions around vaccine prioritization because it wasn't a comprehensive list and it wasn't developed for that purpose. But many states used it for that purpose. So I feel like this issue of not having enough investment in collection of disability data is a huge equity issue that ended up being a life and death issue for people with disabilities during the pandemic. Priya, I don't know if you want to say anything more about that. I do appreciate the research that the Kaiser Family Foundation has been able to do on this.
Yeah, I can say that we've been doing some work with the NHATS data, which I believe stands for National Health and Aging Trends data, which does have some information on unmet need and sort of functional limitations for folks that live at home. That data is restricted to those who are 65 and older. And so that's been one of our struggles with that data set because it doesn't reflect the unique needs of those non-elderly adults with disabilities who live at home and are under 65. So yeah, I would just echo the need for additional data. And, we have been doing research with the available data, but yeah, absolutely additional investment by state and local governments and the federal government is absolutely needed.
All right. Well, Andy, this connects to my history, so I'm happy to hear this, your call for more data. One person followed up on this and asked, do you think that more disability information should be collected in electronic health records, and would that help in getting information out to public health?
Yeah, I mean, I think if we're going to collect disability data in a way that is robust and meaningful, we have to do it in a way that is doable for our healthcare system and our various population-based data collection efforts. So electronic health records is one way to do it. Kind of figuring out how to do it in an electronic health record where the data is meaningful and you have a way of identifying disabilities without asking hundreds of questions is something that we have to figure out. I don't know that anybody has figured out a good way to capture all people with disabilities in an electronic health record. Louis and Priya, I don't know if you've looked at this, but my sense is, like, if you look at the way the census tries to capture disability status, they ask 6 questions, and there are lots of disabilities that aren't going to show up on those 6 questions. So I think this is one of our challenges. We try to get better data and try to make it easy to collect the data. How do we do that without asking too many questions?
Yeah, the one thing I'll add to that is, so we work with Medicaid claims data here at KFF. And again, this is not indicative of the disability population as a whole in the US, but the newer years of Medicaid data, 2016 onward, does have information on disability status of Medicaid beneficiaries, which is very new, and that did not exist prior to 2016. And so it theoretically should give us more information on the services, or on service utilization and enrollment pathways and things like that related to people with disabilities who are on Medicaid, but yeah, not indicative of the US population as a whole by any means.
Yeah, and I don't want to make this too much of a discussion here about the disability data, but yeah, there's a distinction there, as Priya is making, between population data and beneficiary data, because it's not the same overall population. And as Andy's referring to, the 6 questions on which are the ones that are used on the census and have been used in other places as well, as they're trying to use that as with all its warts, it is the one that everybody is using, hopefully, to try to make a consistent population be recorded. And so that was the answer to the person who asked the question about encouraging people with disabilities to report information on themselves to the census. There are 6 questions on the census for that. And it's not just the census, it's the every year sample that the census department does. Next question is, a brief plug. This person says the Massachusetts Department of Public Health included disability questions in their demographic section of their COVID-19 community impact survey and got really meaningful results. And you can find that at mass.gov/COVID survey. And they're also working on ways to pull disability data from electronic health records and would welcome any input on that. Also, let me just sort of step back to a couple things that Andy brought up earlier and let people know that there are other webinars that we've hosted that cover a couple of these topics. The crisis standards of care, we had a presentation on that a couple of months ago and you can find it in the healthcare archive at adapresentations.org, looking at the crisis standards of care around the country and what they were doing or not doing about people with disabilities. And then just last month or a couple of weeks ago, really, on the emergency preparedness, emergency management webinar series in the same adapresentations.org platform. If you go into that archive, you will see a discussion from FEMA and California about setting up the vaccine distribution sites and making them accessible to people with disabilities. So just wanted to add those in there for people to know. Okay, next, I have another question here. In California, at least, there was a county level implementation of the vaccine distribution. So, we saw at our center, we saw reports of quite a few delays for people who were homebound about getting their vaccine, depending upon if their county was, had the system set up well enough, and even had one instance where a person finally received their vaccine a couple of, maybe even in June, I think, and it required a team that came from another county, like far away, maybe 60 miles away. So Andy, I don't know if you saw any of that or if you guys had any discussion about that at the state level about how the counties were an element of this.
Yeah, Louis, that's a great point. And the county variation kind of worked in both directions because there were counties that were prioritizing people with disabilities who were under 65 before March 15th. They went ahead and made the vaccine available before March 15th. So what the state was doing in California was making recommendations, but the counties, at least some of them, felt like it was ultimately up to them how they were going to make their own prioritization decisions. I think over time, the state tried to get more consistency and more centralization, and they hired a third-party administrator at Blue Shield to help them do that. But it definitely felt like the Wild West at different times, different counties kind of coming up with their own rules. And again, sometimes it was based on the quality of the relationship the local public health authorities had with the local disability community. So to the extent that the independent living centers and other groups locally were connected and were part of county level advisory groups, they were making decisions, they were being more creative, they were getting the vaccines to people with disabilities faster. So yeah, you're absolutely right. There's 58 counties in California, and there was a lot of variation, especially in the first quarter of the year.
And Priya, I don't know I know your data is state-based, but did you have anything that you saw or were aware of that went below state level?
I don't think so. I think a lot of our data was more high level. Okay.
And just a reminder to everyone, go ahead and get your questions into the chat room if you've got questions.
Louis, can I ask a question of Priya?
Yeah, absolutely.
So Priya, I know Kaiser, you guys are big, and I don't know if you know the answer to this, but my sense is that the Kaiser Family Foundation was doing its own polling during the pandemic to kind of find out like whether people were ready to get a vaccine and understand better, kind of vaccine hesitancy or vaccine readiness in different populations. And my sense is you all were asking a question that helped identify if, as people were responding to those questions, if they had a person with a disability in their household, and then how that, or a person with a chronic health condition that might make them at greater risk of COVID in their household, and how that affected their vaccine readiness. Am I remembering that right? Is there anything you want to say just in terms of what you all found with your own research?
That's a great question, and I wish I could recall that off the top of my head. We did do some polling around vaccine hesitancy, and we did, I believe, start tracking that back in January, so tracking it over time. I do think there was a question asked about that, and I think it was asked like 2 different times, one earlier in the vaccination process and one more recently. I don't recall what the responses were. That is a different team at KFF that puts out those polls and analyzes the survey responses. Yeah, unfortunately, I can't remember that off the top of my head.
Well, I'm just grateful that you all, thought it was important to identify that as a demographic factor. And I guess
Sure.
that's one of our kind of fundamental opportunities coming out of this pandemic. When we talk about disparities, when we talk about equity, making sure that disability is not just an outcome, but a demographic factor that we're capturing information about. Because as you both know, that doesn't always happen.
Sure.
All right. So coming back to sort of another lesson for either of you, and maybe even just sort of anecdotal concept here about, did anything that you saw or learned feel like it rose to a level of being a problem or a barrier to ADA implementation by the states or local governments, or anything specific related to, the 3 main things about facility accessibility or effective communication or reasonable modification of policies, practices, or procedures? Anything come up?
Yeah, I mean, I'm happy to start from a California standpoint, and then Priya, you may want to chime in. But as I mentioned earlier, Louis, we had a serious problem in California, and I know it wasn't unique to California, with websites not being functional for people with different kinds of disabilities. One of the problems in California is the website, like when you went to sign up for a vaccine, the website would time out if it took you too long to enter your information. And obviously for some people with disabilities, they need more time to enter their information. There were problems with screen reader accessibility, especially for the local public health websites in California. And then if you look at like the mass vaccination sites, their level of knowledge of how to kind of create a process that was going to work for people with lots of different kinds of disabilities varied dramatically. And again, this is where the sites that were supported by FEMA and that were able to tap into the expertise of the California Office of Emergency Services, they started out with a lot more knowledge about how to do these kinds of sites in a way that were going to be accessible for folks with disabilities. So yeah, I think there's an opportunity to educate the public health system in California and around the country with how to respond to a pandemic in a way that is accessible and compliant with the ADA. And part of it's a capacity thing. A lot of these public health budgets have been strained. They've laid off staff, and they don't have a lot of in-house expertise around these issues.
Yeah, the one thing I'll add to that is the new CMS rule around vaccine reporting and education requirements does have some language encouraging intermediate care facilities for those with intellectual and developmental disabilities to make sure that their vaccine education information is accessible. And so whether that's making it available in Braille, providing it to folks in large text format, they do actually have the rules preamble does have quite a bit of information on ensuring that the information for people in facilities regarding the vaccine and vaccine education is provided in an accessible way. And so my best assumption would be that that happened 5-6 months after the vaccine distribution process started. I assume that language was taken from feedback, and that feedback hopefully will be implemented as residents and clients in these facilities are being educated about the vaccine.
Okay. We have somebody, let's see. For those of us who, whoops, there's a few questions coming in here. For those of us who have disabilities and suffered vaccine side effects for several weeks, there seemed to be no support in terms of paid time off or support services. Rather, the focus seemed to be on vaccination compliance. I really felt abandoned during this time. What are recommendations for the future?
Yeah, I mean, so in the employment context, California issued guidance to employers telling them that they should give their employees time off to get a vaccine. But I think you're right, they didn't really get into giving people time off to deal with the side effects of a vaccine, especially if they went on for several weeks. And your comment also just reminds me that there are lots of people who have long COVID, who got COVID during the pandemic and have had long-term consequences from it. That population, in my mind, no question, has protections under the Americans with Disabilities Act. And if you think about an opportunity for the ADA network, educating folks with long COVID about their rights in the employment context, in healthcare settings, in educational settings, I think is a real opportunity, because these are all folks, a lot of them are folks with new disabilities who, haven't necessarily learned about the ADA, don't know kind of the breadth of the definition of disability in the ADA and how to get an accommodation, how to frame an accommodation request. In the context of somebody who's just having long-term side effects from the vaccine and doesn't have an underlying condition, that's an interesting question, whether that would be a reasonable accommodation under the ADA to, have more flexibility around. I mean, it certainly would be good management, but whether that's required by the ADA, I don't know. Louis, do you want to comment on whether?
Well, I think this kind of a question is a very good one, and probably is not the best one for our speakers today, but this is exactly the kind of question that you could call the ADA National Network at 800-949-4232 and talk to a technical assistance specialist, and they'll be able to answer that question for you. All right. One person also mentioned that there were a lot of physical locations made aisles and spaces narrower or put in one-way arrows on the floor that they expected people to follow, or added tables before registers so that people with some mobility issues couldn't reach counters, or did other things that made them less accessible for different types of disability, including but not limited to drugstores. So I think that might just be a comment, but if you want to add to it, you can.
Yeah, the only thing I would add is a lot of restaurants here in Sacramento and around the country, because they couldn't use their indoor space, they ended up creating outdoor spaces that would block access, kind of safe pedestrian access for people in wheelchairs and other folks with disabilities. And some restaurants are trying to continue to use that outdoor space as a way to kind of make up for lost revenue. So I think this is kind of an ADA issue that's still playing out, making sure that whatever the workarounds are as restaurants expand outside, that we still have good, safe, accessible pedestrian access.
Yes, that is true. And we have had many calls from jurisdictions about what to do about these situations and how can they deal with the restaurants themselves, because sometimes the restaurants just built these things themselves. Um, so, um, Next question. In terms of future pandemic planning, which I think we should all start developing a comprehensive plan for as soon as possible, what are the biggest lessons this pandemic taught us to inform our handling of one in the future? And I'm going to add a little bit to that, which is because I was going to ask that question too. It's right now. I mean, there's a long-term future, and then there's actually the short-term future. Andy, you mentioned that the vaccines are now, going toward children. So there's a similar question about whether, we're prepared and have this correct for children with disabilities, and also what would happen should we all need to get a booster shot, in the future. So what do you think the lessons are that might be applicable here, or are we prepared? And I guess.
I can give a quick response to this, which is I think leveraging local community leaders and people that are trusted in communities that we have sort of struggled to disseminate the vaccine to. So that is communities of color, people with disabilities, these communities where there are these local trusted leaders, giving them more power and sort of having them lead these efforts to, I guess if we're talking specifically about, let's say, these booster shots that we may have to get in the coming months, leveraging the power and network that these communities already have, giving them the resources that they need to be able to reach people that they know the best, I think is where I would start.
Yeah, just kind of reiterating what I tried to touch on in my remarks. To the extent that we have made an investment as a country in disaster preparedness and response that is going up over time, because through global warming and other reasons, we're having more and more disasters. And we've kind of made a decision to lower our investment in public health. I think we really have to ask the question, does it make sense to put public health in charge of responding to a pandemic, or to put the emergency preparedness and response infrastructure in charge and have public health as an advisor to them? And I feel like in California and a lot of states, we gave public health a huge task that they didn't either have the expertise or the capacity to do well. So I think that's maybe the answer is you need an all of government response and figure out different roles. But I feel like public health was asked to do too much in this pandemic, and I don't know that it's fair to expect them to play the same kind of leadership role in the next pandemic.
Okay, and sort of related to that is this comment came in. I think this is awesome that disability community now actually have a voice within this new administration. I thank you for your work and dedication. We are seeing cities being sued around the country for failing to address Title II and Title III accommodations. How can we get them to become more proactive in regard to the ADA in their initial planning stages? The ADA at times seems to be an afterthought. And before you guys take a crack at that, let me just say that is the purpose of the ADA National Network, and we are trying to reach out to people, but it's hard to get to everybody, and we're doing what we can to educate people publicly, but people have to know what they don't have to know, that they have an issue to approach us many times. So there is that. Anybody want to add anything?
Yeah, I mean, one thing I'll add is I think that I'm seeing a phenomenon that more and more people with disabilities are running for political office, and many are starting at the local level, but we're seeing it at every level of government. So my hope is that that's going to help in terms of having elected officials at the local level, whether they're on city councils or they're the mayor or county executives, who have lived experience with disabilities and are going to prioritize accessibility and are going to organize themselves as a network of elected officials with disabilities who can kind of steal each other's good ideas. When I look at local jurisdictions around the country, the city of Chicago really stands out for me as a city that has invested in a cabinet level position, the mayor's office for people with disabilities, which, is certainly compared to other cities, it's a well-resourced office with competent leadership who can really help the whole city make good decisions around accessibility. And I feel like we need more entities like that across the country, so that there are people sitting at the table with the mayor who have real expertise and have lived experience and can help the city make good decisions.
Yeah,
Yeah.
Sorry, go ahead, Priya.
Oh, I would echo what Andy said, that things like this, like culture often starts at the top. And so if our elected officials, both at local, state, and the federal, at the local, state, and federal level, if they are talking about it, it's more likely that it will be reflected in the responses to pandemics that we see in the future.
Yeah, and I think the sort of part to emphasize about what everybody's saying here, if you're asking this question, is that there's a role for all of us, everyone, to talk to your elected representatives, talk to people in your jurisdictions, to get them to pay attention and look at the issues about their jurisdiction, their Title II, or even their Title III entities, to be aware of their ADA obligations. So,
Louis,
all right.
One other thing on that comment, and I think, Louis, your network has been part of this, but there's a whole smart city movement happening globally where, cities are trying to use technology to inform decision making and to, be responsive to the needs of their populations, both their residents, but also visitors. So I think that smart city movement is another opportunity to bake in ADA requirements and accessibility requirements as we're developing platforms for, the transportation system or other systems that folks interact with when they visit cities. So I just put that out there as another opportunity. Louis, I'm guessing your network has been connected to some of the folks that are working on that, but that's a kind of an exciting development. Certainly we're seeing a lot of it in California.
Yeah, and different ones of our regional centers have been involved in different ways. So yes. All right. Andy and Priya, maybe you can put your contact information in the chat box for everyone to see. So send it to all panelists and attendees so that everyone can see it. And I want to just tell people, if you still have questions for Andy or Priya and you didn't really get a chance to ask that question, they're going to put their information there in the chat room, so you can ask that question. All right, I'm going to ask this one last question here before we close it up. How did California deal with the inability of individuals differently abled to comply with the 3 CDC protocols as protection from COVID-19? Do you know that one, Andy?
So when I just want to clarify the 3 CDC protocols, I assume they're talking about basic things like social distancing, wearing masks, and hand washing. So I'm just going to assume that that's what they're referencing. And I think what we tried to do, we at Disability Rights California, we worked with the Disability Rights Education and Defense Fund and tried to come out with kind of thoughtful guidance about kind of how mask requirements were going to play out for folks with disabilities, and kind of ways to honor the fact that there are people with disabilities who can't wear masks, and that there are people with disabilities who aren't going to be able to go anywhere if people don't wear masks. So kind of getting that right was nuanced, and we ended up doing some joint guidance with DREDF on it. But I think, as we were talking about earlier, how that played out across the state of California varied dramatically. And we had a pretty strong movement in California that was an anti-mask movement that tried to use the ADA to say that people didn't have to wear a mask, even if they didn't have an underlying disability-related reason for not wearing a mask. So it was complicated. Yeah,
All right.
the answer to that question is yes, it's available on both the DREDF website and the Disability Rights California website. I can see if I can find it right now.
Okay. And while you're looking at that, okay, so let me just reiterate to everyone, if you have any question for Andy or Priya, they've got their information there in the chat for you. If you have a question that relates to the ADA, you can call your regional ADA center at 1-800-949-4232. All right, you all, you will, Andy has put the link for his guidance there in the chat room. So you will all receive an email with a link to an online session evaluation. Please complete that evaluation for today's program, as we really value your input and want to demonstrate the value of it to our funder. And we want to thank Andy and Priya today for sharing their time and knowledge with us. And a reminder to everybody that the session was recorded and it will be available for viewing next week at adapresentations.org in the archive section of healthcare. On our next webinar on July 22nd, we'll be joined by speakers from the Disability Equity Collaborative and the Adult and Child Consortium for Health Outcomes Research and Delivery Science for a presentation on lessons learned from ADA coordinators working with diverse healthcare organizations. We hope you can join us for that. Watch your email 2 weeks ahead of time for the announcement of the opening of registration for that. All right, everyone. Thank you so much for hanging in there and attending today's session. Have a good rest of your afternoon. And thank you again, Priya and Andy. And have a good day, everybody. Bye-bye.
Thanks, Louis.